Okay, good afternoon, everyone. My name is Vicky Bowden. I'd like to welcome you to our HOPP Summer Student Program, our Summer Research Seminar Series. We're so excited to have you all join with us this afternoon for our second lecture. Before we begin, I'd like to share a couple of housekeeping items. So the first is that we will have our speaker speak for about 30 minutes, and then we'll also leave some time for Q&A. And to submit questions here, you'll see the Q&A feature in your Zoom webinar. So you'll just click on that, type in your question, so that way we can collect them towards the end here. So before we begin, I'd like to welcome you to our lecturer. Today we have Dr. Carol Brown, who is a gynecologic oncologist here at MSK, and she's also serving as our first Chief Health Equity Officer, and Nicholls-Biondi Chair of Health Equity. She also serves as our Vice Chair of Health Equity in the Department of Surgery. And with her work, she's focused in three areas: providing high quality and compassionate surgical care to women who are experiencing gynecologic cancers, wiping out cancer health disparities, and promoting public policy to increase awareness, improve care, and increase research funding for gynecologic and other cancers. So again, we are so happy to have Dr. Brown this afternoon, and you can take it away. Thank you so much.
Great. Thank you so much, Ms. Bowden. Great to be here. I'm going to try to share my screen. Is it sharing okay? Yes? All right.
Perfect.
Great. So welcome to all of you who are joining by Zoom. We've all gotten so used to doing Zoom, but I'm used to doing Zooms where I can see the other people, and I'm really, really sorry that I can't see you. But I'm looking forward to being able to interact with you virtually when we get to the question and answer session. I am going to give you kind of a informational lecture to talk about about cancer disparities, but I will at the end talk a little bit about what I do and who I am in my journey, because I know that all of you are here this summer because you're thinking about your passion and interest in science or in healthcare. So I want to share with you a little bit about how I got into that, and again, happy to answer any questions about this presentation, but also happy to answer any questions about that, about myself, my journey, etc. All right, so we'll get started. So Martin Luther King made a quote that of all the forms of inequality, injustice in healthcare is the most shocking. And this is something that has inspired me. I grew up learning a lot about Martin Luther King from my parents. And on the right there is actually a picture of my father, who was also a physician. And I put this as my first slide almost always because I want the audience to know why I do what I do and why I have this commitment and passion to address the issues of health disparities, particularly with regards to cancer. So this is a slide. So now I'm going to show you some things so that you can kind of get an understanding of what is the situation, what's the deal with cancer disparities, what are they, and what's the situation here in the United States. So this is a slide that shows you the new cases of cancer, which is the incidence of cancer in 2020 for males and females in the United States. And I want you to look on each side. You see what are the most common cancers that affect males and females. So for men, it's prostate, lung, colon, and bladder. And women, it's breast, lung, colon, and uterine or endometrial cancer. So you can see that lung and colon are number 2 and 3 for both men and women. And then a cancer of a specific organ that gender only has, for men, the prostate, for women, the breast, is the leading cancer. It's also, I think, no accident that both of those types of cancers, prostate and breast, are related and often are treated with hormonal treatments. Lung and colon cancer, lung cancer specifically, you all probably know this, has a lot to do with environmental carcinogens like smoking, asbestos, other things. And then colon cancer has a lot to do in terms of diet and things in our diet that increase risk for colon cancer. So, but the main reason I showed this slide is I want you to kind of memorize what are the most common cancers in men and women. Now I'm going to show you a series of slides. I'll start with the first one. So along the y-axis is the people by their race or ethnicity, right? And along the x-axis is the mortality or death rate for that cancer. So the mortality rate is the number of persons who pass away from cancer per 100,000 people in the population, right? So this slide is showing you that the mortality rate for Black people with breast cancer is 30 people passing away per 100,000 Black population, okay? And so you can see in this that there's a pattern. Now I'm going to show you a series of other slides more quickly. Now that you know what this one is, they're all the same format, but they're different cancers, okay? So this is breast cancer. This is lung cancer. This is the colorectal cancer. And this is prostate cancer. So if we could do a quiz, I would ask you, what pattern did you see? And you would say you saw that people who are Black or classify themselves as Black have a much higher mortality or death rate than people from any other group. So that's an important thing to remember. It's also important to remember that one of the reasons that we have to understand that we don't have as much information about the death rates of cancer in some of those other groups. But it's definitely true, as for many diseases, including heart disease and some other things, that Black people in the United States have a higher death rate. Now, this slide is looking at a different measure. It's looking at survival time in months along the x-axis, right? So how long people with breast cancer are living, the number of months they live on the x-axis, and on the y-axis is the proportion of people surviving. So it's sort of a way of looking. It's not mortality, it's survival, which is sort of like looking at the glass the other way. Instead of being half empty, it's half full, right? So this means that the higher up the line, or the closer the line is to the horizon, the better is the situation, right? Because you're starting with 100% at the top left corner of each graph. And as you go down, it's a lower fraction of people surviving. So you can see on each one of these that the blue is people with private insurance. And private insurance just means like Blue Cross, Blue Shield, or Aetna, or something like that. And you can see for each racial group, white, African American, and ethnicity Hispanic, if you have private insurance and you have breast cancer, right, you are more people are surviving, and they're surviving longer, right? Because that blue line is closer to the horizon, all right? The red line is people with the red line is people with no insurance, okay? And the green line is people with Medicaid insurance. Medicaid is a federal program for insurance, but it's administered by each state. And for people who have a certain level of income, household income per family, below which they qualify for Medicaid. So the purpose of Medicaid is to give everybody access to health insurance, even if they don't have a lot of money, right? So you'll notice that for people who describe themselves as white for their race, people who have Medicaid, which again, this is insurance, supposed to provide you with insurance, have very poor survival from breast cancer, and it's as poor as those with no insurance. That doesn't make sense. For African American and Hispanic people with breast cancer, people who have insurance that are poor, Medicaid, have worse survival than those who have no insurance. That's the opposite of what we would expect to see. And the importance of this slide is that race and ethnicity are not the only answer, and that race and ethnicity sometimes are more accurately a reflection of other factors like income, like where you live, like what type of toxic substances you are forced to live near because you don't have a lot of money, than just race itself. And that poverty is probably one of the most important social determinants in terms of cancer outcome in this country. And that is a really important point to remember. Okay. All right. So what I do, trying to see if this is gonna, okay, there we go. So you heard that I'm the Chief Health Equity Officer, right? So equity, I show this slide so that equality and equity are not the same thing. When we talk about equity, what we want is that in relation to what we do here at Sloan Kettering, it means that we want every person who has cancer to be able to have the best possible outcome from their cancer, the best survival, the least problem with side effects from their treatment, and to live a full and happy life, right? No matter what their background is, no matter whether they're poor or rich, whether they describe themselves as Hispanic, Latino, whether they describe themselves as Black race, white race, it doesn't matter. We want everyone to have the best, right? So the difference between the concepts of equity and equality is that when you talk about equality, if you think about that apple as being the great outcome from your cancer, equality just means that everybody gets the same size box to stand on, right? So you could kind of look at equality as saying everybody has some type of health insurance, all right? But it doesn't take into account that some people are of different heights. You're giving them the same size box, but the person on the right is the shorter person. So they're starting out not as able to reach that apple. Equity means that you take into account the individual's, what makes that individual have a challenge to getting that great outcome, and you give them the right size box so that everybody can reach the apple, right? So kind of what it means is if we know that the reason that Black men have the highest mortality from prostate cancer than any other racial or ethnic group because they're not getting screened for prostate cancer, that's just a made up fact. But if we know that's the reason, then we can achieve equity by making sure that all Black men get screened for prostate cancer. So this is what myself and my team do here at Sloan Kettering. There are a bunch of different reasons that box might be a different size for a different person with cancer. Some of those reasons or challenges are related to the healthcare system on the right. And these are things that we can do something about. Access to screening, access to treatment, access to follow-up care. The things on the left are things inherent to that person with cancer themselves. And some of those we can't do anything about. We can't change someone's age. We can't and wouldn't want to change their race, their ethnicity, their culture, their language, or we wouldn't want to change their gender or their gender identity, and we can't change their physical ability, but we can affect things like their socioeconomic status. We may not be able to change their socioeconomic status, but we can provide support for those who have less resources. And we definitely can affect things like comorbid illness, means things that are other than cancer, like diabetes, hypertension, that might affect a person's ability to get treated. We can affect that, right? Because we have medicines to treat hypertension and diabetes. We can affect tumor biology because we're learning more and more about the molecular basis of cancer. And maybe some of you are learning that this summer. And we're unlocking ways to kill cancer cells or to block them or to facilitate our immune system destroying them through understanding tumor biology. And we definitely can deal with the lack of trust in our healthcare system that is experienced by many people of color, many people who don't have access to a lot of resources. So the three ways that our Health Equity Office addresses this is through patient care, research, and education and training. This just shows you that our office, the Office of Health Equity, does this by interacting with a lot of different things, a lot of different services and groups and what we call stakeholders at Memorial Sloan Kettering Cancer Center. And that's one of the reasons that it's important, is because this is really a big problem, achieving health equity for people in cancer. And it really takes everyone, almost every department, every service, anybody you can think of is involved in this, meeting this challenge. And our office really serves more as a clearinghouse, as a collaborating force to get everyone together to work on these issues, okay? And you may have heard some talks from people from these different areas. Okay, so I'm going to skip through some of these things pretty quickly, but these are some of the kind of things that we do in terms of community outreach. We go out into the community and we talk about the importance of clinical trials. So clinical trials are when we do research, usually it's studying a drug or a treatment to try to improve the outcome of a cancer. And so it's very important because traditionally, many people don't trust clinical trials, and maybe because of their background, they may be concerned about being experimented upon. They may be concerned that their particular interests are not going to be looked after. So they may be afraid to go into clinical trials. So it's very important that we talk to people, that we increase awareness, that we answer their questions, and most importantly, that we show them that they can trust us, and that clinical trials can often be the best way to get treatment for your cancer. I'm just going to slip through this. So I want to talk very briefly about one program called the MSK Impact Program to End Disparities. So I don't know if you've heard yet about the MSK Impact Test. If you haven't, it is what we would call genomic profiling. So it's when we take the patient's DNA, the person's DNA, and we take the DNA of their cancer, and we analyze both of those to find out, for the patient's DNA, we want to know if they carry some inherited predisposition to getting a particular type of cancer that's been passed down from generation to generation. And for the cancer's DNA, we're looking for those particular mutations in the cancer's DNA or increased copies of certain types of genes that would make that particular cancer vulnerable to an attack directed specifically at that genetic mutation. That's called targeted therapy. And again, you probably have heard some talks about this already. In any case, using that basis of molecular profiling, we've built something that we call the Cancer Health Equity Research Program, where we are bringing our cutting edge clinical trials to people who live in underserved communities here in New York City. And we're using that MSK Impact tumor genomic profiling test to help identify which clinical trials they would be eligible for. We have a lot of really important partners in this effort with the New York City Health and Hospital System, Lincoln Hospital, Metropolitan Hospital, both of those in East Harlem and the South Bronx, Queens Cancer Center in Queens, and Kings County in Brooklyn. And we also know, remember what I told you about, that poverty is actually probably the most important modulator of cancer outcome. And so deliberately, we are partnering with cancer hospitals that are serving the people in New York who have the lowest incomes, because they're at the highest risk of not getting the great cancer outcomes. And so with this program, as I mentioned, we're doing this special genomic testing on all of these people for free, and we're using the results to help identify better treatments, either on a clinical trial or off a clinical trial. This shows that even though you would think that many of these people would be mistrustful of, the fancy smancy cancer center coming into their community, it really turned out that when we meet people where they are, when we treat them with respect, and particularly when people have cancer, it makes us all equal. Everyone is scared to death, literally, and they just want the best possible chance. So we found, surprisingly and pleasingly, that people were very, very willing and eager to participate in this effort, despite the fact that, there's a long history of negative experiences with medical experimentation and so on in this country. So it's very important, because remember what I talked about, those number one cancers: prostate, breast, colon, lung, uterine. These are the cancers that we're seeing in these people, and these are the most important ones that have the biggest disparities. So these are the ones that we're getting the information about. And this just shows that we've really done well in terms of being able to help a significant percentage of people to get onto a clinical trial or get a type of therapy that they wouldn't be able to get at their city hospital cancer center by participating in this program. I want to briefly mention the endometrial cancer, because I am a gynecologic oncologist, which means I specialize in the treatment, particularly surgical treatment, of cancers that affect a woman's reproductive organs: the uterus, the cervix, the ovaries, and fallopian tubes. And for endometrial or uterine cancer, there's one of the biggest disparities of any cancer, that Black women are almost 20% less likely to live 5 years after they've been diagnosed with endometrial cancer. So, and this is endometrial cancer or uterine cancer is a rapidly increasing in the Black community. It's rapidly increasing everywhere in the United States. It's become the 6th leading cause of death, cancer death, in 2020. And I think actually in 2023, it's going to be the number 4. It's going to jump from number 6 to number 4 for women as a cause of cancer death. This is just showing you, though, that at Sloan Kettering, when we looked at the survival of women based on their race or ethnicity, there wasn't any difference. And this is proof that if you can get access to the best care, the best clinical trials, you can often get rid of some of those cancer disparities. We're very good at Sloan Kettering at clinical trials. This just shows you that 1 out of every 3 people that comes to us, no matter what race or ethnicity, no matter what type of insurance they have, we are able to get them onto a clinical trial and therefore give them a chance to have a better outcome. So I think time is kind of running short. So the Endometrial Cancer Equity Program, just briefly, is a specific program where myself and a couple of my colleagues are working with OBGYNs in the community to make Black women aware of the increased rate of endometrial cancer, of the symptoms, and more importantly, of the importance of having the right type of surgery, the right type of clinical trials, et cetera. So this has been really important. And then remember, I mentioned to you that training and education are another pillar for how we address Disparities, and you all are an example of that because you're participating in one of the many really critical summer programs we have here to get everybody, but specifically people who might not otherwise be thinking about going into science, interested in science, and specifically we're hoping that all of you end up being interested in having some type of career fighting cancer. Okay, so I'm going to stop there. Oh, well, before I go on, so I am a gynecologic oncologist, so I have this big administrative job where I am the chief health equity officer and a senior vice president. But at heart, I'm a surgeon. I'm a cancer surgeon, right? So the field that I'm in is called gynecologic oncology. It is a subspecialty of obstetrics and gynecology. So that means to be a gynecologic oncologist, which is a surgical-based specialty, you go to medical school, you do 4 years of an OB/GYN residency, and then you do another 4 years of a fellowship to specialize in gynecologic oncology surgery, okay? So that's 4 years of medical school, 4 years of residency, 4 years of fellowship. That's 12 years before you start actually practicing your craft. So I did that, and I also did a couple of extra years of a research fellowship. And I love surgery. More important, and why do I love surgery? I love surgery because I like working with my hands. I'm a very kind of like immediate result person. I also am obsessed with solving problems and puzzles. Like I can't help it. As soon as I see a problem, I try to start figuring out how to solve it. And the beauty of the surgical subspecialty that I'm in is that every operation is different. Why? Unfortunately, cancer grows differently in everybody's body. So I may operate on Mrs. Jones tomorrow with endometrial cancer and Mrs. Smith on Monday. And even though it's the same operation on paper, it's completely different. So every time I go in and either open someone up or go in minimally invasively, it's like a puzzle to solve. And that's why I love it. I'm just trying to express to you what for me really resonates. I also like seeing an immediate result, right? I know right away if what I did helped or not, which is great. The good thing about GYN oncology is unlike some other surgical specialties, your relationship with your patient does not end after the surgery is over and they've recovered, because GYN oncologists take care of their patients for their entire course of their cancer, and we get to keep seeing them for years after the surgery. So that's the main reason I love it, and I love women's health. I love talking to people. I majored in anthropology in college. So that's kind of how I ended up in that specialty. And I feel very, very fortunate because no matter what else is going on in my career and administrative things, which I also love, and I love health policy and all of that, but I always know that every single day I can say to myself, I have been successful if I have helped one patient. And it could be doing surgery on them. It could be explaining to them something. And that's how I daily measure my own personal success. Or if I feel frustrated or down, I just try to think about, okay, well, I did help so-and-so today, right? Okay, so I'm going to stop there. I think we have some Q&A questions. I think Ms. Baudin is going to read them to me.
Yes. I will. Thank you so much, Dr.
You're welcome.
The first question comes from Namarachi Okukwa. They stated, I'm also interested in surgery. Do you feel nervous at times knowing you're in charge of keeping someone alive while cutting into them? It sounds very interesting, but how do you stay calm? I love that question. Very practical.
That is an amazing question. And it's interesting. So I was trying to give you an idea, like surgery isn't for everybody. And I was trying to give you an idea of the qualities. Notice I didn't mention skill, but the qualities. Like if you don't like working with your hands, you can't be a surgeon. Like, if you don't like immediate result, you can't be a surgeon. And this is something else. Like, if you can't handle like pressure, like immediate, like intense pressure, then you could be a surgeon, but not like a cancer surgeon, and you also can't be an obstetrician. I'll get into that in a minute, because you have to be able to deal when stuff suddenly goes really badly. It's also like being an emergency medicine person. Some people like thrive on that. I do not thrive on complete chaos, which is how I knew I did not want to be an obstetrician. I didn't want to be an obstetrician because most of the time, 90% of the time, it's just, honestly, you're just standing there helping nature do what it normally does. I mean, that's a natural process. But that other 10% of the time, you have no idea what's coming at you. And suddenly you may have like someone bleeding to death and the baby's dying. And it's like, oh my God, it's just crazy. I couldn't take that because it was too much. It was too much at stake and too quick, right? So the kind of stress that you're talking about that I would deal with would be if I'm doing a case and then I get into like really bad bleeding, right? So it's something that you learn over your training as a surgeon to prepare for. And you build up a way of doing it. You're taught how to deal with it. It's like flying an airplane, though. Surgeons have drilled into their heads, this is what I do in a case of emergency, just like an airline pilot, right? And really good surgeons, like trauma surgeons and other cases, you actually drill for these emergency case situations so that you can stay calm, stay focused, and just do what you know to do. So that's how you do it. But you also have to be somebody that can say, and so for me, I will not lie to you and say there's been plenty of times when I have felt very panicked, and it can even happen now. And one of my colleagues and I were talking about this. Sometimes you do everything you're supposed to be doing, and then they just keep bleeding, and then you do get a little knot in your stomach, and you're like, oh snap, like this is really, really bad. But what you have to do then is just focus even more. You breathe in, you breathe out, and you just kind of go into a zone. So that's how I would answer that question.
Great, thank you. The next question, they ask, is there ever pressure for the clinical field to keep up with the research and development field, or vice versa?
So the beauty, I think it's beautiful. I love learning. I think one of the amazing things about a career in oncology is that you learn on the job, and it is essential that you keep up with the research. And one of the benefits of being at Sloan Kettering is that we don't have to go anywhere to do that. Any given day here, there are 5 or 6 different lectures, seminars on everything from the most basic science to clinical advances. It's just incredible. It's lifelong learning. And honestly, I think any kind of scientist, any science-based career, it is lifelong learning. You have to want to learn lifelong in order to go into this. It's not a chore. It's not pressure. And you learn how to do it. So that's one of the good things about it.
Great. The next question, they ask, have you ever faced any obstacles throughout your career? And I'll add a question to that. How have you overcome said obstacles?
Okay. So I'm going to speak to an obstacle that and to give you guys some very practical advice. I've encountered many, 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 many obstacles in my career, but the most important one that has happened over and over again has to do with when other people question your ability or your passion or your commitment, and letting that get inside your head and letting it make you doubt yourself. So I know by the fact that all of you are participating in the summer program that you already have within yourself and probably within your support system, whether it's a teacher, or your family, whatever, you've already got that, I can do this, right? You got to hold on to that, and you've got to believe in yourself. You've got to listen to your family, to your friends, to the people that are telling you you're amazing, that tell you you can do it. And you've got to learn to own that because unfortunately, you will encounter at different stages people who are like naysayers or who may question your ability. And it's just really important to believe in yourself. And it's also really important to know that when you're feeling that way, you should go to those people that have your back, right? And it can be your friends, because you're about to embark on a really long journey and you can do it. As long as you believe in yourself, you can do it. So that's I think the most important thing to remember.
Okay, great. Thank you for that, Dr. Brown. The next question I wanted to ask was from Emma McCarthy. They stated, your work is incredible. Thank you so much for the presentation. So what do you think is the fate of inequality in the broader healthcare system, being that so much of it is based in privatized insurance? How can the disparity be fully bridged if so many people have inadequate healthcare?
Great. Thank you so much. So I was actually just recently appointed to President Biden's cancer panel. So, which is sort of like the culmination of my many couple decades career in health policy. And as part of working with then Vice President Biden on the Cancer Moonshot and the Cancer Initiative, and also in a lot of my work with other organizations on healthcare policy, Emma, you have hit on the key issue here in the United States of America is health access to healthcare is really responsible for the majority of disparities in healthcare, including cancer. And if we could have a system that gave everyone access to quality healthcare, then a lot of these disparities would go away. The issue is, though, that we have a fee-for-service based system in the United States, which means, and I don't think that's going to go away. So we have to find a balance between fee-for-service and what you have, for example, in the United Kingdom, a national health insurance where everyone has coverage and everyone gets access to, basic care and good care. I think for cancer, one of the things that we're working towards is to try to make sure that everyone has access through their insurance to high quality cancer care. And we recently were able here in New York State to help this situation, particularly at Sloan Kettering, where people who were covered by Medicaid managed care, which is like an HMO for Medicaid patients, were not able to come to Sloan Kettering, not because we didn't want them to come, but because the HMO insurance company would refuse to sign a financial contract with us because they felt our care was too expensive. But we were very fortunate in working with some individuals, elected officials and policymakers to get a bill passed so that starting in January, all Medicaid HMOs will ideally have to sign a contract with a Sloan Kettering or another NCI designated cancer center. We're looking forward to this opening up the access. But I do think you are absolutely right. The key to this is making sure that everyone has equal and excellent health insurance coverage or coverage to care.
Great. Thank you so much, Dr. Brown, for that question. I'm going to skip over to Shailene Santana.
Wait, can I say one other thing?
Oh,
so,
yeah.
Probably none of you are old enough to vote yet, but some of you may be old enough to vote in November 2024. And, you should think about these things when you're voting. You should think about healthcare insurance and, climate change, environment. But those are things that you all can do with your vote and your activism, right? So, okay, sorry, go ahead.
Yeah, no, not a problem. I actually wanted to continue on that theme. So with our students, I appreciate that this lecture was about health disparities and cancer disparities, because these are our students are interested in STEM, but I don't think oftentimes they have lectures talking about the broader aspect of like health conditions and how one community may be impacted by another. What tips or even readings or lectures you would recommend that the students, if they want to learn more about health disparities and cancer disparities, where should they go?
So I would say one good source is if you go to the American Society of Clinical Oncology website, ASCO. They have a health disparities committee, and they've actually have some publications on health disparities. So if you go to their website, that's a good one. Also, the American Cancer Society's website also has an entire section, I think, on health disparities. So I would start there. But if anyone is interested in specific diseases and so on, I can give them some references. But I think starting at the ASCO's website is a good start.
Great, thank you. Next, we'll have Shailene's question. They ask, do you think the relationship you have with your patients improves or has affected the chance of their results? And I'm assuming like the cancer outcomes.
That is a very good question. I'll tell you this. As a surgeon, and one of the questions I don't know if we answered it or not, but somebody brought up, it's like, when you do surgery, you are literally taking someone's life in your hands. And when you're in that operating room, you are, you feel that. It's a special relationship and a special responsibility. It is scary, but it's also special. And I do think it's very important for me to feel that the patient can trust me. And I think having that trust and feeling positively towards me as a person, how I interacted with them, is essential for them to have a successful surgery with me, number one. And there have been a few times in my career where the patient and I just didn't click. And I've actually said to patients, I think it's probably not a good idea for me to do your surgery because we're not clicking. Or I sense that, I'm not offended or whatever, but it's really important that you feel completely, at ease or trustworthy. So I think that's one way. But in terms of the person's outcome long-term with cancer, I think it's not so much the relationship with the physician, but it's that person's outlook and relationship with themselves and how them being able to not feel powerless, them being able to feel that they're in control, them being able to see some positivity and act on it, I think is very helpful. And I have seen that make complete difference in how people respond. Unfortunately, I think a lot of that goes along with the support system that people have. So people who are all alone, particularly older people, they have no support. They often don't do well because of that, because they don't have that kind of support and ability to have people building them up and giving them a positive outlook when they're down. So in that aspect, I think it's more about how the individual who's affected by cancer, can attack it themselves. They need to feel that they're doing something themselves, not just being subjected to treatment.
Great. The next question we have there from Jeffrey, it states, have there ever been times where a surgery that you performed fail? How do you deal with this type of failure?
I would have to say no, because the type of surgeries I do, it's not a success or fail, or if it was, it's not failing because of something that I did. I think a better question for a surgeon would be, how would you feel if a patient had a complication, right? Or something bad happened during the surgery, including if you made a mistake or if You feel like you could have done something a different way and they had a better outcome. So it's not exactly a failure. I think that those things are going to happen if you're a surgeon or if you're a physician. And, most people won't admit this to you, but there's no way you're going to be a physician or a surgeon or anything. And certainly if you're a scientist, you're going to make some mistakes. And hopefully the mistakes you make or the errors in judgment that you have will not, the cost of it won't be somebody's life. And I think that's very, very rare. That almost never happens, but it could be something else. And I think that it is a very challenging situation to deal with, but it's also part of the way things are. I mean, you have to be able to accept that, sometimes no matter what you do, the disease is so bad, or, there's something, but there may come a time when you actually make a mistake and you have to be able to deal with that. It's not easy, but, I think one thing that helps is you look at the continuum of all the things you've done and all the people you've helped. But most important is to recognize that most 99.9 literally percent of the time, what you think of as a mistake is actually not your fault. It's the disease. It's you know what I mean? So that's how I would answer that question. But no, it's not. There's very little sense of failure in surgery, I think, or medicine.
Great. It's important to have perspective essentially when you're looking at these cases, because it's not a one size fits all. So
absolutely,
perspective is important. This next question, they're asking, do you believe that the recent restrictions on women's health will worsen the disparity between oncological health inequality?
What I'm going to say is that it is, I don't know whether that is true or not. I think that issue stands on itself. And I think the main implication or the main issue, I think, across the board and is that really the healthcare and what you do as a physician or a surgeon or a scientist really is about the science and the healthcare, and that you can't, it becomes very challenging when there is any external interference in that process or relationship. I think that because, and somebody else had been putting in here some things about specifically pregnancy and cancer. So I think in relation to that specific thing, so cancer is rare during pregnancy, but it can happen. And I think it is certainly possible to think of different scenarios where, restrictions on abortion could interfere or be a problem in terms of caring for a woman with cancer, but it's pretty rare situation. So honestly, I don't think it'll have a major impact in oncology care, but it still is not a good situation and shouldn't be the situation.
That's a great point. The next question is from Camille. What lessons have you learned throughout your career, and what advice would you give someone that wants to follow in your footsteps?
What lessons have I learned in my career, and what advice would I give somebody who wants to follow in my footsteps? I would say, what I said before about believing in yourself and keeping a resource of people who unconditionally support you to go back to in the down times is really critical. I think what Ms. Baudin said about keeping a big picture and keeping relevance of things. So when someone said the thing about failure, so I spent 2 years full time and then more time in the lab. Okay. And so now I'm thinking about failure. Failure is when I spent, and this was a long time ago. Failure is when I spent like 8 hours, making the gel with the right exact amount of SDS and whatever, and loaded the, and had to spin down get the protein and pipette the exact amount in all the wells and da 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 da. And then I turned on the electricity, and then I went home and I came back and it turned out I didn't turn on the electrical outlet wasn't working or something like that. That's failure. Okay. That drove me nuts. I mean, and that's one of the things that made me like, I knew that laboratory science wasn't for me, because I couldn't stand the fact that there were so many other things like out of my control that could go wrong. And like, it was just frustrating. So I think one of the biggest things I would say to you is you're too young now to know it, and resist all this pressure that you have to know exactly what you're going to do for the rest of your life. Like, please don't buy into that, because you will learn more about yourself as every stage. You think you know now, when you get to college, you are going to be a different person. You're going to be a different person as a freshman as you are when you're a senior. You're going to be a different person when you start graduate school. You may, and what I would say is be open to when new things come, to the new person that you are, to new experiences. Like, listen, it just sounds really kind of silly to say, but it's like listening to the universe, right? Like, stuff is going to be out there and you have to be open to it. Don't feel pressure. Like I said, I was going to be a neurosurgeon, so I have to be a neurosurgeon. Like, see what happens. That's really good advice. And here's the secret. You will have many different careers if you stay in this for a long time. You can, you can be a clinician for a while, and then you can be a health policy person, or you could be a basics researcher and then become a clinician. There's a lot of different options, and you have a long time to go. So I think that's really important advice. The best thing is if you get to do what you love and really take the time to figure out what you love and what you're passionate about. That I think is important. Don't succumb to that pressure is you have to do XYZ, you have to go to medical school right away, blah, blah, blah. Don't do that. Do what you need to do. Take time doing something completely different. It's okay, right? That's what I would say.
Great, thank you. There's no blueprint essentially, and everyone's
Correct.
narrative is theirs. So that's great. So staying on the gears of like career and development, we have a question regarding MD versus MD PhD versus solely doing a PhD. The person is asking, what are your thoughts about research versus clinical aspects of the field? And lastly, somewhat related, but also like eyesight in regards to surgery. What are your thoughts on that as well?
I'll answer that one first. It's not like being a pilot. You don't have to have 20/20 vision. Okay. I mean, you can wear glasses, you can wear contacts. So no, it doesn't affect your ability to be a surgeon. So I think it's very interesting, and I think you all are so fortunate, because research for you all is, you're never going to have to spend all day making a gel and extracting the protein and loading up the wells. Like, for you all, research, even laboratory research, is like so much easier, and you can get so much more information more quickly. So I think, honestly, it will be very easy for you to combine the two. And I think it's going to be increasingly necessary that the two are completely bonded. So I think that people who are just MDs like me, you're going to have research as part of your daily life, right? And you're going to have to understand research. You're not going to necessarily have to do basic research, but you're going to have to understand it. I think the MD, PhD, the advantage of that is, I think, the formal training in both the clinical, the understanding of the human body and its physiology and processes, which could then inform you taking the PhD part of it. So if you have a PhD in computational biology and you decide that you want to focus on the brain and how many neurons get fired every second and whatever, and you want to develop a neural processor to alter that for Alzheimer's, I'm just making this up as I talk, then having that MD PhD will allow you see what I'm saying, to take that to another level. And I think the PhD alone is where it may be a science that, or whatever it is, that you don't need, or you're not as interested in the clinical aspect of it. So yeah, that's how I would answer it. And I think that I guess the one thing I would say is that if you're going to get an MD, you guys are going to get an MD, there's going to be so much research involved in your getting that MD. You're going to know so much basic science, as they call it, so much translational science, because that's going to be, I mean, when you guys are practicing medicine, it's going to be all about translational science. So I would say, don't worry if you want to just be an MD. Science is going to be a huge part of what you do.
Great, thank you so much. We'll come to a close. We'd like to thank Dr. Brown again for today's lecture. It was quite informative, and we will be sharing the recording later on. You can visit our YouTube page or also follow us on Twitter when we announce the recording. But again, thank you again, Dr. Brown, for your time. We greatly appreciate it.
All right, thank you so much.
Okay, bye-bye.
Bye.
Bye, have a good afternoon, everyone.